Welcome to the Longevity and Aging series. My name is Evgeniy Galimov, and today I would like to introduce Dr. Amparo Santamaria. Dr. Santamaria is the head of the Department of Hematology at Ribera Salud University Hospital Vinalopar and a faculty member at Universidad Miguel Hernández de Elche in Alicante, Spain. She also serves as the coordinator of hematology and stem cell regenera therapy at IVIRMA Global. Her research and clinical interests focus on hematology, thrombosis, hemostasis, and the integration of new technologies such as artificial intelligence and health into medical practice. She is also recognized as a stem cell and digital medicine innovator, particularly in the field of women's health and fertility. Dr. Santamaria recently published a paper titled Enhancing Oocyte Activation in Women with Ovarian Failure, Clinical Outcomes of Stem Cell Regenera Study using G-CSF mobilization of peripheral blood stem cells and intraovarian injection of stem cell factor-enriched platelet-rich plasma in real-world practice. So Amparo, I hope I didn't make a big mistake in the introduction. If it's okay.
Thank you very much for the introduction.
Yeah,
Thanks.
could you please start by telling us more about yourself and your research background?
Yes, well, as you already said, I think that I'm almost more than 3 decades as hematologist. My area of expertise during all these years has been always hemostasis and thrombosis. And also, I was really interested since I was young about women's health issues, including reproductive years and also the menopause. And now I'm currently the international coordinator in this reproductive hematology unit in the clinic. And our research is focusing in the therapies aiming to restore the function in women experiencing an ovarian failure, and also other fields like thrombophilia and other things that already known about hematologists. I guess that now the new thing is a hematologist doing regenerative medicine in this field. That's the innovation or the new thing in this paper that we also made. We also published the results, so that's the main thing.
So what is the main message of the paper?
When I was writing the results, it was very glad for me. I was glad because the key takeaway of this paper is that combining mobilized hematopoietic stem cells, that's something that we are used to do it, the hematologists, for the reason, for the indication, with platelet-rich plasma enriched with the factors of these mobilized stem cells injected in the ovarian can enable the reactivation of the ovarian in about 70%, two out of 3 women. That is amazing results with ovarian failure. And this help them to reactivate the oocytes production, and then it might help to successful pregnancy in subsequent treatments, or maybe in a natural conception. That's the key. That 2 out of 3 is a very nice results.
Indeed, yeah, sounds very strong results. But let's discuss first the problem. So women who come for this treatment diagnosed with ovarian failure. So can you tell us more about ovarian failure? What subtypes or conditions are included in this? What types of these conditions and how can they be diagnosed?
Well, this is more gynecologist field, but I know something about that because after many years working with them, it's like the ovarian failure is something that happens to women that stop producing oocytes and essential hormones. It's a cause of infertility. And also symptoms that are related or can be similar to a premature menopause. And yes, there are different types of ovarian failures. There are 3 big diagnoses, like can be the diminished ovarian reserve, poor ovarian response, and premature ovarian insufficiency. It depends on the age, it depends on the etiology, but there are clinical definitions that are different from all these types of ovarian failure.
But as I understand, they kind of related. So diminished ovarian reserve can potentially progress to premature ovarian insufficiency in a way. Is it right?
Yeah, there are women that can have a premature ovarian failure, that it can be young when you are 22.
Mhm.
There are people who has a poor ovarian response that it happens during the IVF or something
Mhm.
like that. And also you can have a reserve that is lower than in other women. So it's like you was born with less oocytes, or at least they are not activated in the normal way. So that's the differences. But the diagnosis is based for that I know that an expert has told you in ovarian failure, but there are some limitation and also things that they are also trying to make these three categories. But in the main field, the diagnosis is based on hormone measurements with
Mhm.
the anti-Mullerian hormone,
Mhm.
and also the FSH, that is a follicular stimulating hormone, and also the ultrasound assessment when they can count the antral follicles. So depending on if you have low levels of these hormones, the MEH, the anti-Mulleriana, and also a low number of antral follicles, then they can say that you have ovarian failure or diminished ovarian reserve. That's the most important the important thing that you have to know in order to have this diagnosis. Then you can differentiate in the other three diagnoses, but at the end, the problem is that you don't have enough hormones and you don't have enough antral follicles. Okay, at the moment, there are very few things, few treatments. So they try to make hormonal treatments in order to balance them. Also, there are some therapies related with PRP, platelet-rich plasma.
Mhm.
And I think they have very good results, but it depends on the paper that you read or the group that you read. So there are some controversies. It has very good results, but not many women has the results that we have at control. But this is the only thing that they have in order to achieve. So at the end, the only choice is the ovum donation.
Mhm.
And the ovum donation means that of course, it's your baby when you have your baby, but there are people who has these problems with the genetic voice, the genetic, and then many couples or women, they want to have their own their own babies. And so at the end, many of these women has to go to ovum donation. These results at least give them another chances related with the stem cells and not related with transplantation and other things that are made in other clinical trials. So there are not many treatments for that. So that's why it's so important, these results of this research.
Mhm. So, as you said, there are like three main treatments: hormone replacement therapy, stem cells injection, and platelet-rich plasma injections,
Yeah,
right?
well, the stem cell injection, it was a clinical trial. There
Okay.
is some
It's
clinical
not
trial.
approved yet.
No, because it was made a clinical trial in EV, but they saw that at the end, the mobilization of the stem cells and the injection, the women with stem cells and the people with only mobilization, they have the same good results.
Mhm.
So that's why and also a stem cell transplantation means that you have to take off the stem cells to treat it outside the body,
Mhm.
and then to put it in the ovarian. It's an invasive procedure.
Mhm.
So that's why we decided to make another treatment that it was only mobilization, and to extract the important thing, that is the factors that the stem cells are producing
Mhm.
during the mobilization. And then we take the plasma, enrich it with these proteins,
Mhm.
cytokines, angiogenic factors, so all these things, and then to inject this plasma enriched by these factors. And we don't need to go to make all this stuff that is very invasive, that is a transplantation of stem cells to the ovarian. It has
Mhm.
nothing to, so it's less invasive. And that's why we wanted to know if it was effective, effective and also safe for the patient. So it's not, there are some chances of doing these stem cells, but it's more all the studies that has been made in mouses, and some of them in clinical trials, but none of them has gone to the real life. You know, it's like, okay, we made a clinical trial, but it's an invasive way. We don't know what. So you have to go to the clinical, to the life, normal, usual life. This is the usual way of doing research. You know, when you start with a mouse, and then you start with real women with real pregnant. So we have followed these steps, all these steps from mouse, and we saw that this is the best way, in non-invasive way, to treat it. So the stem cells are that the people who use stem cells are in clinical trials. We are not using the stem cells. We are using the products of the stem cells in the plasma.
So as I understood you right, you do so-called mobilization, which means you apply granulocyte colony stimulation factor, which mobilizes cells from bone marrow into peripheral blood. And then you extract blood, but basically you don't extract stem cells in itself. You just prepare PRP, platelet-rich plasma, which will be enriched with the factors potentially coming from these mobilized stem cells. Is it the right understanding?
Yeah, you have understood very well the treatment, because it's like, a stem cell, stem cells, everybody was. No, you don't need to take off your stem cells, because the stem cells are already, we saw in women with chemotherapy, that when we mobilize them with this treatment and we obtained a lot of stem cells, we saw that women, after the chemotherapy, that the ovarian is burned, you don't have anything, we saw that some oocytes, they have some activation oocytes. That's the hypothesis to start treatment with the stem cells. How do we obtain the stem cells? With the treatment with filgrastim. Filgrastim is just a drug that we discovered 30 years ago. And what is a granulocyte colony stimulating factor. It's a cytokine. The only thing that it is doing is to mobilize the hematopoietic stem cells from bone marrow that are inside the bones to the blood. So it's like, and then we did it at the beginning 30 years ago for facilitate the stem cell collection. But we have seen that we don't, in some cases, in some indication, we don't need to extract to collect the stem cells. We only have to collect the plasma, as you said, using the same technique that the PRP, but this plasma is not the same one as a PRP. It's a PRP that is enriched with the plasma that is obtained after being 4 days with the stem cells in the blood, the treatment. So it's not invasive way.
Now it's more clear. Let's discuss now the cohort, what patients were included, and what were the characteristics in this study.
Well, we included 145 women in the study, but we have made more. And there was more or less aged 26 to 45, 44, because we established this cutoff, until 44. And mostly of them were Caucasian, but we have people from all the world, from around the world. So we have all, and they have problems with fertility treatment failures. Most of them were offered to ovo donation. And when we offer them to try this treatment, of course they say, why not? It's like, and then this is the cohort of women. They all of them, they have these three, or one of these three diagnoses of ovarian failure. And the treatment, it was a retrospective study, because we were doing in our practical life, is a real life one. And then we take all these results in order to know how it was, this cohort study.
And what outcomes did you monitor in this study?
The outcomes, well, as it was a real world, we had to talk about effectivity, and also the safety. Because at the end, this is the studies in real life is a 4 study, it's 1, 2, 3, 4. And then we control where the numbers of how the mobilization was. it was, and then we take into account the numbers of stem cells, the numbers of granulocytes, of neutrophils, because when you see the blood test, what you see is neutrophils, but we know that you can extrapolate the numbers because we know since many years that the numbers of stem cells are correlated with the neutrophils. So we take into account the stem cells, the neutrophils, and also in safety variables, we saw if they have any problems, pain or problems of recovery of the bone marrow. So this is important. So and other important issues that can happen during a mobilization. That's what, and also assessed at the end, but it was assessed just by the gynecologist. This is not my work, but during this treatment, we were taking into account was the stem cells, the neutrophils, and also the safety variables.
But as I understand, you also monitored oocyte activation and pregnancy rates.
At the end, yes, when we make this treatment, the gynecologist make his work, Dr. Muñoz made his work in the clinic, and they make the levels of stimularian and also the ecography in order to see that there was more activation. That's the results are preparing in another paper, because this is more gynecologist results in order to see how many antral follicles, how much was the increase of antimularian. That's another paper because I was focusing on the safety and the effectivity in terms of pregnancy, antral, but I didn't speak about all this stuff because this is another paper that we are going to publish, I hope in aging, for example, but there is more related with the variables of the gynecologist, but this is something that we measure. And so we saw the activation was observed in 70% of the women. And then the activation, the indicators of activation were when you have more than 3 antral follicles, that your antimularian has an increase. So taking into account this, we saw, and the other paper, we will explain how many antral follicles, how was the other biomarkers that are more related or with the gynecologist field. It's like I was focused on my thing, as hematologist.
As you mentioned that you monitored CD34 plus cells, which is basically a marker for hematopoietic stem cells. And you see that there are higher median number of these cells in women who actually got activation of oocytes. So how do you interpret that?
Okay, we try to make many points in many cutoffs, the threshold, in order to know if we have a number of stem cells that we know that we are going to have the higher activation. Because we were extrapolating from the bone marrow transplantation that you need a numbers of stem cells. So we were looking for that threshold that you say, okay, you have. We saw a tendency because I think that we have a small number here in a tendency more or less in 40,000 per 9 millimeters, microliters, 33. So we saw what these levels we have enough for the activation. But we saw also that in other women we didn't need so many. We have a threshold, more or less, of stem cells that we know that we can activate. But we couldn't have real numbers that you say, okay, this is the number we are going to obtain the level. But we have a tendency to have in a higher numbers a better activation. That's for sure. But we didn't know exactly. But more or less is the one that we say here in more or less is 33 per kilograms. We know that is a good threshold.
So basically, you performed some classification analysis and you tried to use ROC AUC to understand the right threshold. But because the predictive accuracy, predictive power was very small, basically negligent. As I understand, 0.5 means like there is no predictive power. So I don't really understand. I think it's not possible to use the threshold Yeah, I guess you just need to get more numbers and maybe more patients and get better predictor.
Yeah, I think that we need, or maybe not. That's something that we want to make more research. Maybe we are extrapolating things that we do in bone marrow transplantation, but it's not the same to remain, to make a bone marrow again, that to make an activation of the ovarian. So it's not the same. A bone marrow transplantation is another thing, and we are extrapolating things that we do in a bone marrow transplantation. So what I mean is that now we are focusing trying to understand if there's no threshold, and maybe we don't need so many, or maybe in the new research we see that okay, we need more. So that's something that this rock has made us to think about it. It's like maybe it's not, we don't need so many, maybe so we have to make more research in this field in order to, maybe we don't need 4 days of mobilization. There are many questions that we extrapolate from the bone marrow transplantation, but we are not doing a bone marrow transplantation, so maybe we don't need so many. So that's something that we have to think about it, and there are future research about these things.
Do you mean
important.
you don't? So the standard protocol for this was like 4 days of mobilization using G-CSF, but you think it's maybe not. There is no need to do it so long, right? Because it's not
We don't know.
transplantation,
We don't know because,
and this is what you want to study next.
that's something that we have to think about it, because at the end we are using something that is established in another pathologies, and everybody's using that like it was the holy, the Bible, and sometimes you have to think that maybe we don't need so many, maybe we only need to obtain this range and it's enough. Or maybe we can tailor it to when we have more biomarkers or more things, we can say, no, these women only need this, and these women need more. There are many fields to make research on that.
I would like to ask you also about this regression analysis. So you did some regression, and it says that you found H leukocytes and CD35 plus cells are important factors and significantly predicting activation for oocytes. But you didn't specify any details on the regression. Can you tell a little bit more on that?
Yeah, we made this analysis in order to know if there were independent variables as all regression studies. And we saw that, okay, the H is an important factor. We already know that. The H was an important factor in order to obtain the results. And also the numbers of stem cells and the leukocytes. The neutrophils and the stem cells are very correlated, so this was not a big surprise. The age, it was also important in order to see that at the end, lower ages would have, when we make the differentiation in the other tests, we saw that lower ages have better results. So every year that is the women waiting, we have good results. But it really correlated with about the stem cells, we saw that this is very important for the results. But when we tried to make the threshold, we didn't find any threshold. But we saw that this variable was important. There is an agreement with the study, so it was. But we didn't find any other important risk or variable that was independent for the results. So we didn't see it.
Also, as you said, the efficiency of this activation was around 70%. Which means 30% of women didn't have any oocyte activation. And I'm just curious, what do you think was the reason for that? Any idea of why this 30% of women didn't achieve?
Well, good question. The thing is that the diagnosis of these entities are very variables. Most of them were insufficiency of ovarian failure. It means that they have a premature problem. That is, and there is a complex disease. And then I think that in many women, it's not only a matter of activate the oocytes. It has to be something else that we don't know by now. That's
Nice.
or we were not in the correct. We need more details for that.
By the way, this approach, when you use some mobilization of stem cells and use plasma enriched with growth factors from these stem cells, what do you know about the mechanisms of this oocyte activation?
Yeah, how they, well, this is something that we say homing effect, the homing effect. It's like the stem cells, they generate a lot of cytokines and angiogenic factors, and they create like a home, not home, like a good ambient environment in the ovarian. And then when they see something that can fix all these factors, made this environment good for the activation for the oocytes. That's something that the scientists that have been doing this research in mouses and ovarian, that they say the homing effect. And this is why they think that this is the mechanism of action of this treatment.
But do we know about the more important molecules and less important factors? Like, I was just curious, how could you monitor efficiency of the treatment, maybe based on some factors we can measure in this extracted plasma?
Yeah,
Is it possible to do something in this
yeah,
respect?
it's possible to do. That's a good question. Yeah, and we have already, we know another scientist of the EV, Dr. Wright, has made these studies in the plasma to know how many factors there are, how the composition of this plasma after this mobilization, and the proteomics has a real change. So with factors that the stem cells are producing. And also we are now trying to do it to see all this, to see the composition and to see how it works not only in mice, but also in cells that are humans, but in vitro, because we want to know, but you can measure, we have made this observation, the doctor right, on mice, and they have characterized the proteins. This is something that is not in the routine clinical practice, but I think at the end we can have some biomarkers that will help us to know not only the numbers of stem cells, That is a very good question. That's something we are working on.
Cool. Just want to move to strengths and limitations kind of conversation. Well, obviously, this study didn't have any control arm. So, as I understand, we cannot really derive any causal relationship. So, do you think it's possible to design a study with control arm to make it more robust in future?
We have been talking about, because there are some issues about doing only with PRP in other clinical trials that there are people trying. At the end, what we have thought that is prior studies show that the stem cell mobilization alone was effective. That's why in the clinic we adopted this like a practical clinical. So, and when you randomize patients at the end, they don't want to be in the control group. With women in a certain period of their lives, that when the time is, is very important, it's very difficult to make it. And then I think that in this case, we already made this clinical trial with the ASCO treatment. We saw that mobilization was good enough. And I think that with this 4-step treatment that now is in clinical practice, we saw that, okay, maybe with the injection of the plasma in the ovarian, we saw that the proteomics changed. So I think it's very difficult to make a control group, very difficult ethically, to inject water in an ovarian, for example. There are some issues that I think that it has not an answer. It will not have an answer. But here you can see a strong association.
Great. I'd like also to talk about the safety concerns. So how safe is it to do mobilization of stem cells? What are the side effects? And
Okay.
and what are the side effects of PRP as well? It would be good to know for me.
Okay, the side effects of the PRP is only when the injection, it's not, we haven't seen any side effects in the long term, because at the end you are injecting a small plasma liquid, and we haven't seen any, because it's an autologous treatment, it's your own cells, your own plasma. So we haven't seen any important issues in not only in fertility, also in other indications. And about the mobilization, that's why we did it, because I wanted to know in women with these characteristics that with their healthy, it's like healthy donors of bone marrow. We are using the same. We saw that even in women with older or younger, we didn't see only the usual ones. That is pain in the headache, pain in the bone, because the bone marrow is inside the bones. I always explain them that. And it's like a flu. There was the only 20% mild effects. And we didn't see any important effect, any important severe, nothing like that. That's why we were aware of that. We make a hemogram after the mobilization in order to see that everything is okay, that you are producing your cells as a normal way. And also we saw if they have any problem, and we didn't see anything. It's our experience as hematologists in bone marrow transplantation mobilization. So it's almost the same.
But how long was your follow-up? Because as I understand, it was just half a year. And the concern, I just saw some papers. Well, I didn't do any very thorough research, but what I saw is that there are some people think there is still some cancerogenesis risk for PRP and for mobilization. And also for mobilization, there could be some like decreased numbers of neutrophils or some other kind of cells in some studies, as I understand. But obviously, all this kind of, well, there are quite limited number of long-term data on safety, and it's hard to
Yes,
find some.
we didn't see it in this cohort, but that's why I control them very well. But when you can see all this stuff that you were telling, because I have made many mobilizations in people who wants a bone marrow transplant. You can see diminution of the neutrophils, of the blood, because when you make to work a lot the bone marrow, you can see that at the end, some people can have bigger time to have a normal values in the hemogram. That's why you need more or less 2-3 weeks. You are okay. And we haven't seen all the case reports that you have seen are more related with people, healthy blood donors, healthy bone marrow donors, because this is the same schedule that we follow for healthy bone marrow donors. We have made a follow-up of 30 years, and we haven't seen any important, this is only case report that you can read it. It's like we have seen, for example, many other things, but we haven't seen in this cohort. It was okay. We always choose very well women, it's not something, they don't have to have any important disease, any important autoimmune disease, because we don't know if it's going to make a crisis of this autoimmune disease. So there are women that are healthy. They only have the problem of the fertility, but they don't have other issues, because they are healthy women who wants to, in a healthier way, to have babies. Otherwise, we have to follow a committee and all this stuff if they want to follow this treatment. So we are very following all the law and all this stuff in order to have these results, because otherwise we don't want that women can have a problem with this treatment. Okay. So I choose very well the women that are going to make this treatment very well.
Great. I'd like to zoom out a little bit and just discuss in general. So how do you think all these conditions of ovarian failure fit into a bigger picture of reproductive aging?
In terms of how they will respond to the treatment?
Is it part of the normal process? Is it like a subpopulation?
When you made the mobilization, which is
No, I'm talking in general about the condition of ovarian failure. How does it relate to normal reproductive aging?
at the end, this is very gynecologist. That's why I'm doubting the answer, because this is very, but at the end, the ovarians aging is a problem. It's a problem for all of them. And then when you see the activation, what you see is that the antral follicles are growing more than, because we know that 40% of the follicles can be sleeping. They say small sleeping, and they sleeping and they don't go out. So the pattern is that they are regenerating this activation. You can obtain more oocytes. And then what happens with that? When you can have a pregnancy, a normal pregnancy, it's like a, and also a usual conception, and most of them have to make an IVF. So with the stimulation, with this activation and with the stimulation of the gynecologist, then they obtain more oocytes that can be used to obtain the embryos. That's why we do that, because we want to obtain more, and then the ovarian is going to change this.
Great. Last question. What's next for your research?
To see how it works in vitro, and also to do all this research, I hope with controls, and I hope we will do it with controls and see which is if you need all these stem cells, or you don't only need, how many days do you need, how many stem cells do you need, and also if one of these, if we can obtain the special or the factors that we need, and we don't have to do all this mobilization. So there are many research projects that we are trying to obtain the results and see if we have more options for those women.
Well, Dr. Amparo, thank you very much for your time, and I wish you all the best for your research.
Thanks to you. Sorry for I have spoken too much, but it's okay.
Well, it was great. Thank you.
Okay, bye.
All the best. Bye-bye.
Bye.